Okay, this short lecture concerns ourselves with the assessment and the management of the breathing. We have checked for danger, we have checked for the response of the patient, we have sent for help, we have assessed and managed an airway, and we're now happy that, at least for the moment, the patient has a patent airway. We can move on to assess the breathing. We're looking to assess the work and the effectiveness of the breathing. So expose the patient's chest and look at their general appearance. Do they have any signs of pallor? Do they have any signs of cyanosis? Look for any signs of trauma. Is there any bleeding? Is there any contusion? Is there any foreign objects in the chest? Attach a SATS monitor at this point if you can, and look for chest expansion. Once you've done the exposure of the patient, check for the trachea to see if it's central, percussion both sides of the chest at the top and the bottom, and auscultation throughout the chest as well. This whole assessment of breathing should take you less than a minute and give you lots of useful information about the patient's breathing condition and the effectiveness of their breathing. You may be able to hear stridor, you may be able to hear wheeze, maybe other signs you can pick up. First thing that needs to be managed as a matter of priority for breathing is a tension pneumothorax. In a tension pneumothorax, air is escaping from the lung but is unable to get back into the lung and causing hyperexpansion of one side of the thorax. The first sign, the patient, they will often have been traumatized and they'll have respiratory distress. They may have been in a car accident or other trauma situation, and they come in very breathless and distressed. When you expose the chest, you may see unequal chest expansion, you may see hyperexpansion on one side of the chest, and when you percuss, you'll get hyperresonance on the side that's affected and absent breath sounds on the side that's affected. As the tension pneumothorax develops, it pushes the trachea and the mediastinum away from the lesion. So if you have a right-sided pneumothorax, you have hyperexpansion on the right side, you have absence of breath sounds on the right side, and the trachea will be deviated across the left-hand side of the patient as it's pushed away from the lesion. In these pictures we can see both a radiological evidence of a tension pneumothorax and its management. And the bottom right-hand side of the screen depicts a left-sided tension pneumothorax with a hyper-expanded left side of the chest, absent lung markings on the left-hand side of the chest. The mediastinum and the heart is shifted across to the right-hand side. The left hemidiaphragm is also pushed downwards. On the top right, we can see the surface anatomy markings for what we call the needle thoracocentesis, which is the emergency treatment for a tension pneumothorax. So this patient on the top right has a right-sided tension pneumothorax and is about to have a needle thoracocentesis mid-clavicular line, second intercostal space. Once you've palpated the mid-clavicular point, you go down to the second intercostal space, 14 gauge wide bore IV cannula at 90 degrees straight through the skin until you get a hissing noise from entering the hemithorax, and then you withdraw the needle and advance the cannula into the chest. This reduces that compression and turns your tension pneumothorax into a pneumothorax and allows the mediastinum to return to its central position. In the top left you can see a 14 gauge cannula which is left in situ with the patient with a small catheter coming off of it, and then what we call a Heimlich valve, which is a one-way valve attached to the bottom of the catheter. If you suspect the patient has a pneumothorax, the signs may be one of a trauma patient with respiratory distress and unequal chest expansion on one side or the other, reduced percussion note and reduced air entry on one side or the other, and if there is blood within the chest, you may get a reduced percussion note at the base of the affected lung. If you suspect a pneumothorax, you need to place a chest drain. If you have done a needle thoracocentesis for a tension pneumothorax, of course you've created a pneumothorax and you will need to insert a chest drain. Sit the patient at a 45-degree angle, make sure they have a patent airway, put them on the monitors, give them some analgesia, fentanyl or maybe ketamine. Do your surface anatomy, which is the 5th intercostal space in the mid-axillary line. Mark your site, prepare your equipment, sterilize the area. Insert your local anesthetic and aim with a scalpel through the skin just above the rib below 5th intercostal anterior axillary line. Make a 2 centimeter incision, and then once you're through the skin, do blunt dissection with forceps through the 3 muscle layers of the chest down to the pleura, using plenty of local anesthetic, as the pleura is an exquisitely innervated structure and is very, very tender. Once you've punctured the pleura, you can insert your little finger and have a feel around to make sure there's no bleeding and there's no other foreign bodies in the area. Remove the trocar from your chest drain using a wide bore 14 gauge drain. Insert that with your fingers or your forceps, never ever the trocar for fear of myocardial damage, and advance the chest drain towards the head of the patient. Secure with a suture and attach to an underwater seal drain, and then find the x-ray to see if your chest drain is in position. There's a video to demonstrate this in due course. Here's a picture of a patient who has a chest drain inserted. Note that the chest drain is 5th intercostal space, which is approximately in line with the nipple. It is in the anterior axillary line, and it's secured there with a purse string suture which has been wrapped around the tube and secured tightly. Note this is a trauma case, where you can also see a non-invasive blood pressure cuff, 3 ECG dots and a hard collar placed. Moving on from tension pneumothorax and pneumothorax, we're going to have a quick discussion about stridor. Stridor is a very common condition, often presenting in children with croup under the age of 5. It can be very distressing for the child and very distressing for the parents as well. Upper airway noise and often struggling to breathe, increased work of breathing, and sometimes desaturation. The management is lots of reassurance, oxygen for the patient, monitors, and then the immediate management of acute stridor is nebulized adrenaline, where you can use 4 mL of 1 in 1,000 solution and nebulize that through oxygen over 5 minutes. You should find a good improvement with the stridor, but be aware that the stridor can deteriorate over the next 30 minutes and the nebulized adrenaline may need to be repeated. Further to that, the treatment for stridor is steroids, and often oral prednisolone is the best choice, but bear in mind that steroids take several hours to work and are not part of the acute ABC management of the patient. Okay, just going back through the slides, this is the most important slide. Really exposing the patient as soon as you get to breathing, looking at the work and the effectiveness of the breathing. Look at the appearance of the patient, look for pale cyanosis, signs of trauma. Attach the SATS monitor, palpate the trachea, percussion both sides of the chest, auscultation both sides of the chest. If you find a problem with breathing, treat it. If there's wheeze, you treat it. If there's suspected tension pneumothorax, treat it. If there's suspected pneumothorax, you need to treat it before you move on to circulation.